Xin chào tất cả các bạn. Bằng việc nghiên cứu những mẫu bệnh phẩm sinh thiết của những bệnh nhân tử vong do COVID-19, các nhà khoa học đã phát hiện ra các hiện tượng rối loạn đông máu ở những bệnh nhân này, cụ thể là có sự tăng đông khi nhiễm SARS-CoV-2. Hôm nay chúng ta sẽ được bác sĩ Shivi Chan đến từ khoa huyết học thuộc trường đại học y khoa Rush ở Illinois thuộc Chicago, Hoa Kỳ, trình bày về những cập nhật điều trị chống đông ở bệnh nhân COVID-19 người lớn. Hy vọng sau bài trình bày này chúng ta sẽ giải quyết được các vấn đề như có phải tất cả các bệnh nhân nhiễm COVID ở người lớn cần được điều trị chống đông hay không, những loại thuốc nào ưu tiên được lựa chọn, liều lượng ra sao và thời gian dùng là bao lâu. Và đặc biệt chúng ta sẽ tìm hiểu thêm các khuyến cáo chống đông ở những phụ nữ mang thai khi nhiễm COVID-19. Vâng, xin mời các bạn cùng lắng nghe.
Welcome to our update on COVID-19 coagulopathy and anticoagulation guidelines for adult COVID-19 patients. In December 2019, Wuhan City, the capital of Hubei province in China, became the center of an outbreak of a pneumonia of unknown cause. By January 7, Chinese scientists had isolated the novel coronavirus from the affected patients. This was named as Severe Acute Respiratory Distress Syndrome Coronavirus 2. In February 2020, World Health Organization named it Coronavirus Disease 2019 or COVID-19. I have created a timeline for the COVID-19 pandemic and included certain key dates. December 31st, China reports to WHO for cases of pneumonia, all connected to the Hunan seafood market. January 7, Chinese authorities identify the novel coronavirus. January 21st, first case of COVID-19 is reported in the United States in the state of Washington. January 24th, first case of COVID-19 in Illinois and Chicago. January 31st, WHO declares COVID-19 as a global public health emergency. March 11, WHO declares COVID-19 a global pandemic. Illinois shelter-in-place order went into effect on March 21st, 2020. And here are our updates. According to the WHO, on June 23rd, there were about 9 million confirmed cases with 475,000 deaths across 216 countries. You see here the latest numbers of cases of COVID-19 in United States and Illinois. And there is also a comparison from when I first did this webinar on April 29th of 2020. At present, we have about 2.3 million cases of COVID-19 in the United States with 120,000 deaths. In Illinois, the cases are now about 140,000 with close to 7,000 deaths. We all know this person. She is the Prime Minister of New Zealand, Jacinda Ardern. After several weeks of lockdown, New Zealand had achieved its ambitious goal of eliminating the coronavirus. This had already happened when I did this webinar in April. New Zealand now stands as an example. The country has only recorded 1,515 cases and 22 deaths and has had no new cases since May 22nd. So let's take a minute to review again the pathophysiology of COVID-19 associated coagulopathy. We are all familiar with the Werkho's triad: endothelial injury, hypercoagulable state, and circulatory stasis lead to the development of thrombosis. In COVID-19 infection, excessive inflammation causes endothelial cell dysfunction. ARDS requiring mechanical ventilation leads to stasis. Increase in the inflammatory markers, activation of platelets, decrease in antithrombin and tissue factor pathway inhibitor, liver dysfunction, and reports of development of antiphospholipid antibodies all lead to a hypercoagulable state. And we see changes in the hematological parameters like D-dimer and fibrinogen levels and clinical outcomes due to arterial and venous thrombosis presenting as myocardial infarction, strokes, venous thromboembolic events, and disseminated intravascular coagulation. The slide here, shared by Dr. Ghazi from our division, shows SARS-CoV-2 virus and the spike S protein that binds to the ACE receptor. What we now understand very well is that endotheliopathy appears to contribute to the pathophysiology of microcirculatory changes in SARS-CoV-2 infections. The receptor for viral adhesion is an ACE2 receptor on endothelial cells. Virus replication causes infiltration of inflammatory cells, endothelial cell apoptosis, and microvascular prothrombotic effects. The consequent microcirculatory dysfunction contributes to the clinical sequelae in patients with COVID-19. From a clinical perspective, in addition to the systemic hypercoagulability and potential for thromboembolic complication, the described microvascular endothelial injury with microcirculatory clot formation noted in post-mortem evaluation is consistent with an thrombotic microangiopathy that may occur in these patients. The endotheliopathy may also explain reports of cerebrovascular complications in younger patients, myocardial ischemia, and increasing reports of both micro and macrocirculatory thromboembolic complication. Shown here is an image where on the left, the normal interface between the alveolar space and endothelial cells is depicted. The right side highlights pathophysiological features of coronavirus disease 19 in the lung, including loss of vascular integrity, activation of the coagulation pathway, and inflammation. Across all different studies addressing COVID-19 associated coagulopathy, the most common hematologic abnormalities that we have seen is increase in the D-dimer levels, prothrombin time prolongation, troponin elevation, thrombocytopenia, which is usually mild, and lymphocytopenia. And we still continue to see that amongst these parameters, D-dimer levels are seen to be significantly higher in patients with severe infection, patients requiring ICU admission, and the non-survivors across all studies. We all know this study where Tang et al. Described retrospective data of 183 patients with COVID-19 infection. The notable differences between the survivors and the non-survivors was that non-survivors had about a 3.5-fold increase in D-dimer level, 2-fold increase in fibrinogen degradation products, and PT prolongation. 71% of COVID-19 patients who died fulfilled the ISTH-DIC criteria. Even though the non-survivors revealed significantly high D-dimer levels, it is not advised to base treatment decisions regarding anticoagulation solely on the D-dimer levels. Diagnosis of thrombosis, especially pulmonary embolism, is important in patients with severe COVID-19 infection, as appropriate management can change patient outcomes. But VTE still remains underdiagnosed in COVID-19 patients due to diagnostic challenges, given the risk of exposure to other patients and healthcare providers, and patients' own condition and positioning. Several studies now have reported a high incidence of venous thromboembolic event in COVID-19 patients, as shown here. The French study was a retrospective study of 26 patients with severe COVID-19 infection admitted to the ICU, reported a high incidence of 69% of venous thromboembolic event in these patients. But this is all still based on retrospective and observational data. The results of prospective randomized controlled trials are eagerly awaited to develop a better understanding of COVID-19 thrombosis. Shown here are 5 trials currently in the United States, and there are 11 around the world, which are focused on anticoagulation in COVID-19 and are actively recruiting. And there are many more down the line that are ready to recruit. DIC is a common complication in critically ill patients. According to our RUSH anticoagulation guidelines, we recommend that the DIC panel should be checked prior to initiation of enoxaparin and be monitored every 48 hours. Like any other scenario, to treat DIC, the first step is to treat the underlying condition. According to the recommendations made by the American Society of Hematology, in COVID-19 positive patients with lab parameters consistent with DIC but no active bleeding, there is no evidence that correction of lab parameters with blood products will improve patient outcomes. But for patients who have lab parameters consistent with DIC and are actively bleeding, it is advised to transfuse blood products to keep platelets greater than 50, INR less than 1.8, and fibrinogen greater than 150. The hemostatic effectiveness of tranexamic acid is unknown in this setting and is not recommended at this time. So, what is the current landscape of anticoagulation in COVID-19? I would like to start by saying that all guidelines to date suggest that thoughtful use of proven evidence-based approaches must be carefully balanced with integration of rapidly emerging evidence and growing experience. According to the American Society of Hematology, Anticoagulation Forum, which is a North American organization of anticoagulation providers, and NIH COVID-19 treatment guidelines following will be concluded. So, should all COVID-19 positive patients get venous thromboembolic prophylaxis? Yes, as long as there is no bleeding risk or complication. Pharmacologic prophylaxis is advised. Low molecular weight heparin is the agent of choice. Mechanical prophylaxis should be used where pharmacologic prophylaxis is contraindicated. So, what should be the intensity of the anticoagulation? Non-ICU patients should be treated with standard dose of VTE prophylaxis. Dose should be based on body weight and renal function per institution protocol. Critically ill patients with no documented evidence of VTE can be considered for intermediate dosing, like enoxaparin 40 milligrams every 12 hours. Critically ill patients with documented venous thromboembolic event or high clinical suspicion based on presence of right heart strain on an echocardiogram, for example, can receive therapeutic anticoagulation. The key point to remember here is that a full 3-month course of therapeutic anticoagulation is recommended for patients with COVID-19 who are presumed to have a hospital-associated venous thromboembolic event. Repeat imaging later in the course of patient's illness and basing anticoagulation duration recommendations on such imaging is not recommended. So once you start, you should complete 3 months of anticoagulation. So who gets post-discharge prophylaxis and what dose and for how long? Consideration for post-hospital VTE prophylaxis may be reasonable on a case-by-case basis for patients with COVID-19 who are at low risk of bleeding. Decision should be made as a result of a multidisciplinary discussion and should be based on patient's condition during the hospital stay as well as at discharge. Along with that, consider other risk factors like advanced age, history of cancer, history of prior VTE, thrombophilia, obesity, hormone replacement therapy, and patient's ability to have access to medication. Currently, according to the American Society of Hematology, it is recommended that patients who meet the above criteria can either be discharged on betrixaban 160 milligrams on day 1, followed by 80 milligrams daily for about 35 to 42 days, or rivaroxaban 10 milligrams daily for 31 to 39 days. Should biomarkers like D-dimer be serially measured to trigger changes in care? The guidelines recommend that D-dimer measurement may be used as a marker of illness severity and prognosis. Rising D-dimer should necessitate further thromboembolic workup. However, guidelines suggest against intensification of anticoagulant dosing based only on biomarkers such as D-dimer. So, should thrombolytic therapy be used in patients with COVID-19? Guidelines recommend against use of thrombolytics in patients with COVID-19 outside of a clinical trial setting unless there is another clinical indication like ST elevation MI, acute ischemic stroke, or high-risk massive PE with hemodynamic compromise. So when should patients on chronic warfarin therapy be transitioned to a DOAC in the setting of COVID-19 pandemic? It is suggested that patients taking warfarin in outpatient setting be switched to shorter acting agents like low molecular weight heparin or unfractionated heparin when initially hospitalized in case their clinical condition changes, renal function changes, or there is need for invasive procedures. It is recommended that patients who were not eligible for a DOAC therapy prior to the COVID-19 pandemic should not be switched to a DOAC therapy during the pandemic. This includes patients with mechanical heart valves, severe liver dysfunction, or combined renal dysfunction, and drug-drug interactions that preclude safe DOAC use. So then, how can COVID-19 exposure risk be minimized for patients on chronic warfarin therapy? So it is recommended that for patients on chronic warfarin therapy, transition to a DOAC if possible. Otherwise, refer for patient self-testing. Extend interval of INR monitoring. Use face masks, social distancing, and good hand hygiene before and after during a lab and clinic visit. Seek care at non-respiratory clinics which are not seeing patients with upper respiratory tract symptoms. Avoid busy lab times like Mondays or weekday mornings, and use drive-up fingerstick INR checks if possible. So now I would like to share some updates for rush anticoagulation guidelines for adult COVID-19 patients. In line with the recommendations discussed in the previous slides, our guidelines recommend VTE prophylaxis for all low-risk COVID-19 patients. Enoxaparin is the agent of choice, and the dose is based on creatinine clearance and BMI as shown here. Anticoagulation is held in presence of active bleeding or if platelets are less than 25,000 or fibrinogen is less than 50 milligrams per deciliter. For high-risk patients who are defined as patients receiving mechanical ventilation and D-dimer greater than 6 times upper limit of normal, or those who have acute kidney injury as shown here, therapeutic dosing of enoxaparin based on BMI and creatinine clearance is advised. Bivalirudin is recommended in case of low molecular weight heparin failure or concerns of heparin-induced thrombocytopenia. We use anti-10A activity to monitor the adequacy of anticoagulation with goals as shown here. Anticoagulation is held in the presence of active bleeding or if platelets are less than 50,000 or fibrinogen is less than 100 milligrams per deciliter for therapeutic anticoagulation. For intradialytic anticoagulation, dosing is deferred to the expertise of nephrology service. For renal replacement therapy, enoxaparin 30 milligrams IV once, preferably prior to or within 1 hour of starting dialysis, is recommended. Bivalirudin is the agent of choice in case of liver injury, concerns for heparin-induced thrombocytopenia, or if the patient has enoxaparin failure, and also for patients who are receiving extracorporeal membrane oxygenation or ECMO. We added recommendations about anticoagulation for pregnant patients. As shown here, all low-risk pregnant patients with suspected or confirmed COVID-19 should receive prophylactic unfractionated heparin upon admission to reduce the risk of venous thromboembolism. For high-risk, critically ill pregnant patients with confirmed or suspected COVID-19 infection who are less than 22 weeks of gestation or postpartum, enoxaparin should be considered. Dose should be based on creatinine clearance and BMI as shown here. Anti-10A activity is used to monitor the adequacy of anticoagulation. For high-risk, critically ill pregnant patients with confirmed or suspected COVID-19 who are greater than 22 weeks of gestation, unfractionated heparin should be considered due to its short half-life and easy reversibility. Remember, unfractionated heparin, low molecular weight heparin, and warfarin do not accumulate in breast milk and do not induce an anticoagulant effect in the newborn. Therefore, they can be used in breastfeeding women with or without COVID-19 who require VTE prophylaxis or treatment. Direct oral anticoagulants are not routinely recommended due to lack of adequate safety data during pregnancy. For post-discharge prophylaxis, we updated our guidelines. Initially, we were basing the duration of anticoagulation on the renal function. But now, we updated to state that prior to discharge, all high-risk patients who were previously on therapeutic anticoagulation but without a confirmed venous thromboembolic event may transition to a DOAC at prophylactic doses. We recommend use of rivaroxaban 10 milligrams daily for patients who have a creatinine clearance greater than 30 or apixaban 2.5 milligrams twice daily for 4 weeks. In patients who do not have insurance coverage for a DOAC or in whom a DOAC may be contraindicated, prophylactic doses of enoxaparin may be used for the time frame of 4 weeks. Warfarin will be considered in patients who have a confirmed heparin-induced thrombocytopenia. All high-risk patients on therapeutic anticoagulation with a confirmed VTE can transition to a DOAC at treatment doses on discharge. Rivaroxaban 15 milligrams for 3 weeks twice daily loading dose followed by 20 milligrams daily, or apixaban 10 milligrams twice daily loading dose for 7 days followed by 5 milligrams twice daily. In patients who do not have insurance coverage for a DOAC or in whom DOAC may be contraindicated, they can use treatment doses of enoxaparin. Warfarin should be considered in patients with heparin-induced thrombocytopenia. These are some of the key resources that we can still continue to tap into to answer all our when, where, how, and what if questions. I would like to take a moment to wholeheartedly thank all my colleagues for their support, without whom these guidelines and this webinar would not have been possible. So thank you, everyone. You can always email me your questions at my email, shivi_jane@rush.edu. Please stay tuned for future updates regarding anticoagulation and COVID-19, and thank you for watching.
Vâng, bài học đến đây đã kết thúc. Cảm ơn các bạn đã chú ý lắng nghe. Nhớ like, share and subscribe để theo dõi các bài học tiếp theo. Xin chào và hẹn gặp lại.